Hi, folks. I'm guessing that folks will continue to stream in, but I want to make sure that we get full use of this hour. Welcome to the I-STARR webinar series. I see some familiar names in the waiting room. So if you've been to an I-STARR webinar, some of this introductory stuff will be very familiar, but for those who haven't, I-STARR stands for Infrastructure for Studying Treatment and Addiction Recovery Residences, and the I-STARR project aims to develop infrastructure to advance science on recovery housing, particularly recovery housing for persons treated with medications for opioid use disorder, or MOUD. Today is our 46th webinar. It's hard to believe. We've been at this for a while. And we'll be hearing from Dr. Meenakshi Subbaraman, who will be discussing cannabis use among sober living house residents. So if you've been to a webinar before, you'll remember that the I-STARR project is supported by a grant from the National Institute on Drug Abuse, and is part of the larger NIH HEAL initiative that's helping to end addiction long term. And it's also one of several projects that comprise the Consortium on Addiction Recovery Science, or the COARS network. So just a couple of quick housekeeping notes about the format of this webinar. So all audience members are currently muted. We encourage folks to use the Zoom chat function to introduce themselves, to connect with fellow audience members, and to ask questions of our presenter. So we do have an I-STARR staff member monitoring the chat, and we'll unmute audience members at the end of the presentation so that folks at that point can raise their hands and participate in discussion. You may also have noticed that we don't allow AI note takers into the webinar, but this webinar and each webinar in the webinar series is being recorded so that folks who are unable to attend today can still be able to learn from the webinar. In fact, all registrants will be emailed a recording of the webinar to listen to it at their leisure, even the ones who showed up. So finally, just a quick reminder also that closed captioning of the webinar is available within Zoom, and you can find it using the functions or the buttons at the bottom of the Zoom screen. Let's go to the next slide. So let me tell you a little bit about the I-STARR team. So I'm Amy Maracle. I'm a research scientist in the Alcohol Research Group at the Public Health Institute. I co-lead the I-STARR project with Dr. Carmen Masson, who's a professor of psychiatry in the School of Medicine at the University of California, San Francisco, or UCSF. The team also includes co-investigators Sarah Zemore and Lenny Jason, communications specialist Diane Schmidt, the team's project coordinator, Quinoja Capitani, and our biostatisticians, Libo Lee and Meenakshi Subbaraman, who you'll be hearing from today. Let's go to the next slide. So the I-STARR project and all the I-STARR project activities are guided by an absolutely amazing 18-member advisory board comprised of a diverse group of leaders from across the country. So our advisory board represents recovery and recovery housing leaders, treatment providers and payers, national policy advocates, as well as researchers and educators. Let's go to the next slide. Can we go? Oh, perfect. So let me tell you about today's presenter, Dr. Meenakshi Subbaraman. So Dr. Subbaraman is a program director and a biostatistician within the Behavioral Health and Recovery Studies Group at the Public Health Institute based in Oakland. Before joining this group, Dr. Subbaraman worked with the Alcohol Research Group for 15 years, where she served as the Director of Statistical and Data Services. Much of her research focuses on alcohol and cannabis policy, including issues like spillover effects or potential unintended harms or benefits related to policies. She also has expertise in cannabis research, including cannabis as a substitute for alcohol or other drugs, and cannabis use during pregnancy. Recently, Dr. Subbaraman worked as a biostatistician on the National Study of Treatment and Addiction Recovery Residences, or the I-STARR project, and on Dr. Doug Polson's studies of sober living houses in Los Angeles. She also has ongoing projects on alcohol policies, such as how blood alcohol content limits, BAC limits, are for driving are associated with alcohol-related outcomes. And our most recently funded project will characterize cannabis use in sober living houses and assess how cannabis use in these settings is related to other substance use outcomes. So we're excited to have Dr. Subbaraman present today. And without further delay, let's turn things over and hear what she has to say about cannabis use in sober living houses. Take it away, Meena.
Thank you so much, Amy, for the introduction, and thank you all for your attendance today and your interest in our topic, cannabis use in sober living houses. Before I get into the content, I want to shout out to the study team at Behavioral Health and Recovery Studies, Doug Polson, who's now retired but was our program director. He was the PI of a couple of studies that I'll be referring to. We used data from his studies that were designed for other purposes to do some secondary analyses around this topic today, cannabis use in sober living houses. So thank you, Doug, for your leadership on those. Liz Mahoney is our senior research coordinator. Liz is in the virtual room with us today and will be fielding some of the questions in the chat, especially those questions that are more about clarification or factual questions. Liz can answer those in real time, but we'll save the more discussion type questions for after I get through the slides. Thanks also to Dr. Miracle and Dr. Zeemore for their contributions to BHRS and our studies there. I also want to acknowledge our funding from NIAAA and NIDA. As I mentioned, Doug was the PI for the first two studies, which are now completed, but we did use data from those studies for these secondary analyses. And I am the PI of the last study listed here, which was just funded to look at this same topic, cannabis use in sober living houses. Okay, so jumping into the content, as folks probably know, recovery residences are substance-free living environments for folks who want to abstain from substance use, pursue recovery, and do so while living with others who are doing the same. Recovery residences have a lot of different names. They vary quite a bit in terms of the structure, programming, practices, the services that are offered. But despite these differences, there are some common elements, for example, requiring abstinence for residents, which is particularly relevant for the topic today. So in terms of what recovery residences look like and do, for those who are less familiar, this table is from the National Alliance of Recovery Residences, or NAR. And NAR lays out 4 different levels of support, ranging from level 1, peer run, all the way up to level 4, or treatment provider kinds of houses. So as we move up in this spectrum, these houses, or these different types of houses, increase in their intensity in terms of the physical structure, the staffing on site, governance, and programming. So we can see that there's quite a bit of difference in terms of each of these factors across the different levels. But regardless of what level we're talking about, there are some common elements like mutual help, peer recovery support, and responsibility within the household, as well as substance use monitoring, which again is particularly relevant for what we're talking about today. And that comes in the form usually of drug testing of residents. So for most of the talk, I will be focusing on sober living houses in California, which are an example of level 2 houses. But before I get into our studies on sober living houses, I wanted to go over some results from the I-STARR study that Dr. Miracle mentioned. Dr. Miracle was the PI of this, the National Study of Addiction and Recovery Residences. So we have here some results about the programming and policies and practices around abstinence, drug testing, and medications of concern. But for this study, just to take a step back, what we did here, we started by developing a database of all the recovery residences that we could find across the US. This involved looking at SAMHSA treatment locator, the NAR, National Alliance for Recovery Residences list, as well as a lot of Googling and detective work to try and track down all the houses that we possibly could across the United States. And in doing that and developing the database, we found more than 10,000 houses. And then what we did was administer a survey to about 840 houses. So we were asking in that survey about services offered, staffing on site, and policies and practices around requiring abstinence, drug testing, and accepting residents who are taking these various medications. So I have here on the right the question that was used to ask about accepting residents who are under a physician's care and are taking the following medications that are listed there. So, what we found in this survey was that there was nearly universal requirement of abstinence in the recovery residences across the US and nearly universal requirements of drug testing of residents. In terms of acceptance of residents who are taking the various medications, there was very, very high acceptance of MOUD and MAUD. But as we go down the list, we see that the acceptance goes down. So stimulants for ADHD and other psychiatric meds was only about 58 to 56%. Opioids or narcotics for pain was a little bit lower. And marijuana or cannabis was quite low. We only see about 6 to 7% of acceptance of residents who are taking cannabis for medical reasons. So now moving on to our sober living houses, now that you have the kind of overview of what's going on at the national level in terms of acceptance of these various medications, especially cannabis, we'll move into the sober living houses. So as I mentioned, these are an example of level 2 houses. These are peer managed houses that usually follow the social model. Residents can rent rooms on a monthly, indefinite basis, but generally live according to their own schedule without following any sort of structured program or timeline. Regular attendance at 12 steps or other mutual help is generally required or encouraged, but support comes from peer involvement in the house, participating in things like household chores, rather than from a clinical staff on site. So in terms of an estimate of how many houses there are in California, this estimate of roughly 1,000 comes from 2 statewide organizations in California. So that's CCAP, the California Consortium of Addiction Professionals, which is the NAR state affiliate in California, and the Sober Living Network, which is an organization of sober living houses in Southern California specifically. So between these 2 organizations, we estimate that there's roughly 1,000 houses, but of course it's true that not all houses in California are certified or belong to these organizations. So this might be a little bit of an underestimate. Okay, so now that we have some background on different policies and practices across the nation and what are sober living houses, why are we examining cannabis in sober living houses in particular? You know, we saw that there's a very, very high, almost universal requirements of abstinence and of drug testing, very, very low acceptance of individuals who are taking cannabis. So why even look at this question? So I'm going to give you a few reasons. First off, there have been a number of studies and much more as cannabis has become legal in more and more states, studies that have looked at the issue of whether cannabis can be used as a substitute for alcohol and other drugs. So this is just a handful. And like I said, there's been many, many more since legalization has become more prevalent. So in terms of the support for cannabis as a substitute for alcohol, this has been seen among medical cannabis patients who do often report using cannabis as a substitute for alcohol. Among individuals with alcohol use disorder, there have been a handful of studies that have found that cannabis use is related to reduced alcohol use. And a review of the research on cannabis substitution for alcohol, which was written by yours truly, did conclude that cannabis met or partially met 6 out of 7 criteria for substitute medications for alcohol. So I have one example of the criteria, which is to reduce alcohol use and misuse. I thought that folks might be interested in what the other criteria are. So I have a list here. So the first one is reducing alcohol use and related harms. The second one is to be free of harms or at least less harmful than alcohol. The third is to have less misuse potential than alcohol. The fourth is to be actually used as a substitute rather than alongside alcohol. The fifth is to be safer in overdose than alcohol. The sixth is to not potentiate or exacerbate alcohol's effects. And the seventh is to have significant health economic benefits. So as I mentioned in the review that I wrote, cannabis met or partially met 6 out of 7 of these criteria. And if folks are interested in that paper, I can definitely send it to you. So despite what's been found in support of cannabis as a substitute for alcohol, the risks related to cannabis use in terms of how it's related to alcohol use might depend on other factors. For example, whether cannabis is being used for medical versus recreational or other reasons. In terms of the support for cannabis as a substitute for other drugs, this has also been seen among medical cannabis patients, as well as in community-based samples of people who use drugs. Among individuals with substance use disorder, cannabis has been reported to be used as a substitute for opiates, both among people who inject drugs, as well as by adults in early recovery from opioid or stimulant addictions. Harm reduction benefits are often cited as reasons for why people are using cannabis as a substitute. For example, because it has fewer adverse side effects and less withdrawal potential than other drugs. And as for alcohol, some have even suggested that cannabis could be used as a substitute medication for opioid use disorder. So another reason, in addition to the scientific literature on this topic, another reason why we wanted to look at cannabis use in sober living houses is because of the messaging out in the public that people might be seeing related to this issue. So if you live in a state that has legal cannabis and a state that has legalized advertising for cannabis on billboards, you might have seen billboards like this. So billboards that are really pushing this message, drawing a very distinct comparison between cannabis and other substances. So we see, for example, on the top left here, hello marijuana, goodbye hangover, hello marijuana, goodbye headache. Marijuana is less toxic, less addictive, less scary than alcohol. These comparisons are also being made to opioids. On the bottom left here, states that legalized medical cannabis saw this massive reduction in daily doses of opioids per year. So again, this messaging is out in the public. If you don't live in a state with legal cannabis, or you don't live in a state that allows these kinds of billboards, you probably still have access to the internet and might have seen articles that are talking about this phenomenon of California sober. So for those who are less familiar, California sober refers to using cannabis, but not alcohol or other drugs. So this phenomenon has gotten a lot of buzz lately, no pun intended, in a wide variety of publications. So we see it in Fox News, The Guardian, Wall Street Journal. We see it in the San Francisco newspaper, the SF Gate. So, the gamut of different publications, no matter your political leaning. And like I said, this has gained a lot of traction in the past couple of years, not just in terms of the number of publications that are talking about this, but also talking about how famous people are engaging in this. So Willie Nelson says he's California sober. Billy Idol says he's California sober. This article from the Washington Post on the right talks about Jelly Roll, the country singer. So Jelly Roll, who declined to participate in the story, abstains from cocaine and opiates, which wreaked havoc on his life and landed him in prison. But he smokes weed. Marijuana has kept me sober, he said. So again, there's this really prevalent message that's getting out into the public about the idea of California sober and these famous people that people might look up to that are engaging in this. So another reason why we wanted to look at cannabis use in sober living houses has to do with the NAR policy guide on medical cannabis. So in 2021, NAR put out this policy guide in response to the state affiliates asking for some guidance on how do we deal with cannabis, medical cannabis in our recovery residences. It's becoming legal in more and more places. There's talk about substitution. What do we do? And so NAR put out this policy guide in response, and it says that no state affiliate is required to allow the use of medical cannabis within their residences. But if they do, here are some guidelines on how the houses can handle it. So, for example, all residents using medical cannabis must possess a current medical cannabis card issued by a licensed medical practitioner. Combustible products are not permitted. Products must be kept secure, doing product inventory, random product counts. So just some guidelines on how to help deal with this in the houses if the houses do decide to allow medical cannabis use among their residents. The NAR policy guide also explicitly says that medical cannabis is also included as an alternate or substitute for prescription opioids and or opioid abuse and addiction treatment in the states that are listed here. So all of these factors, the literature on cannabis use as a substitute, the messaging that people are seeing out in the public, the articles around California sober that have really proliferated recently, all of this is what led to our research question: how is cannabis use related to alcohol and other drug use among California sober living house residents? If it is being used as a substitute, we would expect that cannabis use would be related to less alcohol and less other drug use. So let's find out. Okay, so in order to do these analyses, as I mentioned, these are secondary analyses that use data from studies that were designed for other purposes. So these are Doug studies. This first one is the neighborhood study. The study was designed to look at neighborhood level factors and house level factors that are related to resident outcomes. So we took data from this neighborhood study to look at our question on cannabis use. In terms of a sample from the neighborhood study, data came from 557 residents living in 48 houses in LA from 2018 to 2021. And in our studies of sober living houses, we always recruit the houses first. So we get permission from the house to recruit, and then we go ahead and recruit residents from the houses. So we can see here in the middle is some information about the houses that were recruited in terms of the gender served, the average number of beds, and the monthly fees. And then on the bottom, we can see the eligibility criteria for the residents to participate in the neighborhood study. This is the geographic distribution of the houses from the neighborhood study. For those who are familiar with LA, they're pretty wide. You know, LA is a very big area. The houses were pretty widely distributed across the county. We did for the neighborhood study, because we were interested in neighborhood level factors, we did sample across socioeconomic status of the neighborhood to ensure that we had variability in terms of the neighborhood level factors that we were looking at. And you can see again how these are all distributed across the county. So the second analysis that we did was from the helping study. So that study was designed to look at helping behaviors among residents in the houses. So again, the study was not designed to look at cannabis. I want to say that caveat, but we did use data to do some secondary analyses. So for this, data came from 205 residents living in 28 houses in LA from 2021 to 2023. And again, we recruited the houses first, and you can see the distribution in terms of gender served, average beds, and monthly fees. And then we recruited the residents from those houses that agreed to participate. And on the bottom, again, is the eligibility criteria for the helping study. Okay, so in terms of the demographics of our samples, this table is actually from the neighborhood study. The breakdown of demographics was really similar for the helping study. So, and it's quite similar to what we usually see in the sober living houses, where it's about 2/3 male, 40% white, a little more than a third Latino Hispanic, 70% single, never married, and average age of about 39. Okay, so what did we find? So in terms of the prevalence of cannabis use within the houses, we saw that this was pretty steady between baseline and 12 months. So for the neighborhood study, the final time point was 12 months. And we saw that about a fifth reported cannabis use in the past 6 months, both at the beginning of the study at baseline and at the end of the study at 12 months. But at any point in the study, we saw that almost a third or 30% reported cannabis use in the past 6 months. So relatively high prevalence of cannabis use happening in these houses. In our longitudinal GE models, when we looked at how cannabis use was related to alcohol and other drug use, we saw that across the board, cannabis was related to worse outcomes. So we saw that cannabis use was significantly related to higher odds of alcohol use, more drinking days, higher odds of alcohol problems, higher odds of drug use, more drug use days, and higher odds of drug problems. In our second sample from the helping study, we saw that the prevalence of cannabis use was a little bit lower, but this is because we only had data on past 30-day cannabis use. So this was now a shorter window. In the previous study, we had data on 6-month cannabis use. Now it's only 30 days. So it's not so surprising that the prevalence is a little bit lower. But we did see that still about a quarter reported any past 30-day cannabis use at any point during the study. When we replicated the longitudinal GEE models, we saw again that cannabis use was related to worse outcomes. So again, higher odds of alcohol use, more drinking days, higher odds of alcohol problems, and higher odds of drug problems. So here we have a couple of figures. The one on the left is from the neighborhood sample, and the one on the right is from the helping sample. And what we've done is ordered the outcomes on the left of each figure, drinking days, problems, and any drinking in the same order, so that you can see how the magnitude of the effect, which is the little diamond, and the precision or the confidence interval, which is the horizontal line around the diamond, you can see that the pattern is really quite consistent between these two samples, both in terms of the size or how far it is away from one, as well as the width of the confidence interval or that horizontal line. And so what this suggests is that the results are quite consistent because we got such similar results in both samples. This gives us more confidence that the findings are real, that the association actually exists. We have that dark blue line at 1 because that is null or no effect. And so again, all of the point estimates or the diamonds are away from 1. None of the confidence intervals cross 1. So these are significant associations, again, that are consistent between the two samples. So for the helping study, we also added a question towards the end of the study. And thank you to Liz Mahoney for this idea. I think this was really clever that we were able to do this. And I think it did help us in terms of getting preliminary data for our recently funded project. So what we did was we asked 47 residents directly, have you ever used cannabis with the purpose of substituting alcohol or another drug you usually use? Only 1 reported currently using cannabis as a substitute. So that does kind of corroborate what we saw in the longitudinal models, right? Only 1 is using cannabis as a substitute. And on average, we were seeing that, well, it doesn't seem like it's being used as a substitute because it's related to more alcohol and more other drug use. That being said, 29 or almost 2/3 of the 47 folks that we asked directly did report that they ever used cannabis as a substitute. So they weren't currently using it, but they had tried it in the past. And anecdotally, when I had presented these results to NAR a while back, someone in the audience, who I believe was a house manager, said, well, oh yeah, these are people who have tried everything. They tried substitution, they tried everything, and it didn't work. That's why they're here. So I thought that was an interesting observation, and I'm curious what folks in the audience think about that, if folks have experience with that too. Of course, it's anecdotal. It's just the one house manager who said that, but that was something that stuck with me. So as I mentioned, these are secondary analyses of existing data that came from studies that were not designed to look at cannabis use. These studies were designed for other purposes. So we did not have detailed measures on cannabis use. And that's a major limitation of the analyses that I just presented, because what we would like to be looking at are things like quantity, motivations for use, medical use, which we know is relevant, and recovery goals. The results are also limited in terms of their generalizability because, of course, in California, cannabis is legal. So these results might differ in states that have different laws. And the houses in our studies were also all part of the Sober Living Network, which does have a certain level of standards for certification. And so that might also affect how these results can be generalized to other houses. So to conclude, what we found in these secondary analyses in 2 samples of California sober living house residents, cannabis does not appear to be used as a substitute for alcohol or other drugs. We found that it was related to worse outcomes in terms of alcohol and other drug use. If it were being used as a substitute, we would expect it to be related to less alcohol and less other drug use, which is the opposite of what we found. That being said, I want to acknowledge, as NAR acknowledges in their policy guide for medical cannabis, that cannabis use may benefit some people and harm others. So, the one person who says that they're currently using cannabis as a substitute, I believe them. We did not find that on average, but I do believe that if that person says that they're using it as a substitute, I want to believe what people say. So this is a very tricky issue. And of course, NAR recognizes, as do I, that an absolute ban on medical cannabis could prevent the appropriate use of cannabis. So there's a number of conditions that are not recovery or substance use disorder related, like epilepsy or glaucoma, for which people can be using cannabis appropriately and effectively. So before I move on to the next few slides, I just want to take a moment and say that I'm not advocating for cannabis to be allowed in sober living houses, despite my past research on cannabis as a substitute for alcohol. This is not something that I'm saying should be done or should be allowed. I just wanted to present the data and what we have found. And the next few slides are going to get into cannabis-friendly sober living houses, which again, I want to be very explicit that I'm not advocating, but I'm just presenting to because it's interesting, and hopefully the discussion around it will be interesting too. So what is a marijuana or cannabis-friendly sober home? So thank you again to Liz for finding this blog post, which came from Patrick's Purpose Sober Living, which is a sober living home in Sherman Oaks, California, in the LA area. So this blog post points out a few conditions: chronic pain, glaucoma, PTSD, and eating disorders as examples for which medical cannabis can be used effectively. And so in this particular sober living home, they're saying that they only allow medical cannabis use. And so the residents are not allowed to use weed recreationally or to get high. They must be using it to treat a diagnosed condition and receive a prescription. So this is somewhat in line with the NAR policy guidelines around medical cannabis. They also say that they ensure that the clients who are using medical marijuana are seeing a doctor, sticking to recommended dosages, and attending medical marijuana meetings for people in recovery, which I thought was interesting. That was something that I haven't heard a lot about. So the blog post goes on to talk about rules and expectations. For example, abstaining from drug and alcohol use aside from medical cannabis consumption, only using cannabis that is prescribed, and adhering to randomized drug and alcohol testing. So again, this particular house is following the policy and practices which we saw from the I-STARR study, which are very prevalent, like requiring abstinence besides medical cannabis and adhering to random drug testing. So we saw in I-STARR that those are highly prevalent practices in recovery residences. So despite this house allowing medical cannabis, they're still following policies and practices that are commonly followed in recovery residences. And so finally, what I wanted to point out from this blog post is that this house, Patrick's Purpose, supports clients who use medical cannabis by creating a support meeting specifically for them. And these meetings focus on combating the stigma of cannabis in recovery. So again, this is something that I hadn't heard much about before, and I thought this was interesting. I was curious if folks in the audience have any experience with this, so we can talk about that during the discussion portion. So I have another blank slide just to repeat that, again, I'm not advocating for medical cannabis to be allowed in sober living houses. I just wanted to present this as an example of a house that is doing so, in case folks are interested, and we can talk about it more. Okay, so in terms of our future directions, we, as mentioned, were recently funded by NIDA to assess cannabis use in sober living houses. So again, because the analyses that I presented are secondary analyses, we didn't have the really rich data on cannabis use that we wanted in order to, or that we need really to assess these questions. So what we're going to be doing is collect detailed longitudinal data to look at similar questions. We're also going to collect data on policies and practices around cannabis use, for example, how these policies are enforced and whether residents make decisions about where to live based on these policies. Another aim of the study is to develop an assessment tool to categorize policies in the sober living houses around cannabis, and eventually in future studies, look at how these policies are related to outcomes. So these are the specific aims of our newly funded study. As I mentioned, we're going to be comparing alcohol and other drug use, as well as mental health and recovery capital outcomes between individuals who used cannabis versus not. We're going to be collecting detailed measures on frequency, quantity, mode, reasons for use, motivations, medical use, all of those kinds of data so that we can look at this aim. We are also going to be assessing reasons why individuals who live in sober living houses use cannabis, how these are related to outcomes, and how this aligns with recovery and living in an abstinence-based environment. And as I mentioned, we're going to be looking at the range, or identifying the range of current cannabis use policies and practices so that we can develop the assessment tool for use in future studies. An important part of our new study is our Community Advisory Board, our CAB. So our CAB is going to be providing feedback on measures and what data we should be collecting at the beginning of the study. So we're going to be having a 1-hour focus group meeting next month to get some feedback and perspectives on cannabis in sober living houses. And then we'll have a couple more meetings, or a few more meetings as the study progresses, to get feedback on the results, on the assessment tool, and things like that. So if you are interested in joining our CAB, please email me. We are looking for especially recovery house owners, operators, managers to join our CAB and to give us feedback on what we should be looking at, what kind of measures, etc. We already have a few members, including someone from the Glendale Police Department. We have someone from a treatment center. We have a couple folks from recovery residences in the LA area. So again, if you're interested, please email me. We will be reimbursing folks for their time, not a lot, but a little bit to show our appreciation. So please do reach out if you're interested in joining. So I wanted to end with a few questions for discussion. I mean, I'm absolutely happy to focus on the questions in the chat instead, but I also wanted to throw out some questions in terms of what we've been thinking about on our study team. So for example, given prior evidence that supports cannabis as a substitute, why did we find in our secondary analyses the opposite? Why was cannabis related to more alcohol and other drug use among sober living house residents? I'm curious if folks have thoughts on that. What kind of guidelines should be put in place if sober living houses or other types of recovery residences do decide to permit medical cannabis? For our new study, if you have ideas what we should be looking at, what measures we should include, please chime in. And finally, a question that came up in a discussion with a friend recently: how should sober living houses and recovery residences handle residents who work in the cannabis industry or the alcohol industry? I thought that was kind of a provocative question. So yeah, if you have thoughts on any of these, or of course your own thoughts or your own questions, I look forward to those for our discussion. Thank you so much for your time and for your interest. And I'm going to go ahead and stop sharing so we can start discussing. Thank you.
Thank you, Meena. Oh my gosh, that was an amazing presentation. And thank you for providing folks with your contact information. We have some time set aside for questions and for discussion, but we may not get to all people's questions. So thank you for sharing how people can contact you afterwards. So at this point, we do want to open things up for folks who may have questions about anything that Mina presented or who want to dive into the discussion questions that she provided for us. And you can do that by either raising your hand and we can call on you, or just dropping a question into the chat. We do have folks monitoring the chat and we can raise questions that way. But I do see some hands up already. I see Heidi Springle with her hand up. Heidi, do you want to unmute yourself?
Not Heidi. This would actually be Ron.
Okay. Oh, Ron. Okay,
Yeah,
wonderful.
Heidi was ill today. Actually, there was a mix-up in our registration, and I apologize for being late to the meeting too. Um, the first question. So I'm with MAR, Maine Association of Recovery Residences in Maine, as executive director. In 2022, we had about 80 houses that we started hearing that people were using medical cannabis, much along the way that Pact's promise was medical card, doctor's prescription, needing to continue along the rules. And so we presented to our board a proposal or policy to allow medical cannabis. It was the only time our board was not unanimous on anything, but they did approve it. We also, Amy, you may remember, went to the national group, uh, to Beth Fisher and the rest to have a look at, because there was no one in the country doing that at the time among the NAR affiliates, and they kind of gave it a wave and a blessing. We had four of our residences that adopted the policy, and at the end of 3 years, only one was willing to continue it because of the problems that were associated with medical cannabis use. Again, much along the NAR standard. Matter of fact, the language of the NAR policy was very much what we had proposed at first with MAR, almost word for word. And there were various reasons for that. It kind of blessed substance use in a way, even though I'm a medical doctor. I've studied medical cannabis for a long time. Not a personal user of it these days. It's important to kind of stay where you stand because of the widespread use of recreational cannabis. It wasn't hitting the mark. The people that really could have benefited from it were overwhelmed by those who were abusing it. People would go out for a walk with combustible THC or vape pen, and then come back to the house, and it was obvious that they were getting high. So we rescinded the policies for about 2 years now, almost 2 years since that was rescinded. We still have people using cannabis. It's not like it's gone away. So it's still a challenge, but that's just a thumbnail of what our experience has been. We're at about 120 houses now, 1,600 beds to give you an idea of our size and scope. But I'm more than willing, going forward, to share, in more detail some of our experience.
Thank you
So
so much
Ron,
for sharing. That was really interesting to hear about the evolution of that policy in Maine. Thank you.
I wonder if Mina's finding from her work, the secondary data analysis work, rings true with your experience,
Uh,
that you have this policy you allowed people to use and there were negative effects.
yeah, there were. We were not doing recovery capital outcomes data in the beginning, but we instituted that kind of in the middle. So it's hard to do a complete longitudinal analysis, but Generally, we would tend to agree that with that observation that we saw increase rather than decrease use, and not just with cannabis, but with associated substances. Uh, this whole thing came about because people were being kicked out of recovery houses, and I use that term specifically instead of referred and discharged. They were being kicked out for positive THC and then dying of a fentanyl overdose on the street. And that was the motivation to adopt this to prevent those deaths from happening. Um, we don't think we prevented that many.
So Paul Stevens, I see that you have been patiently waiting with your hand up.
Hey, thanks. Good afternoon or good morning, wherever you are. And I work for Oxford House, so this is coming from my experience there. And this is, I realize this is a little adjacent to your study, but it's certainly something I think worth considering, which is that it is my understanding, and this is coming from Oxford House Incorporated's general counsel. I am not a lawyer, but the overwhelming majority of sober homes rely on protections from the Fair Housing Act in order to be able to get an accommodation from local government zoning laws, right? Most local governments are like only 4, 6 unrelated, and if you want more than that, you say fair housing protects us because individuals in recovery from substance use disorder are considered a disabled class. But it's very clear as far as how that works that they have to be abstinent and in full recovery from substance use disorder. And according to our lawyer, the second there's someone using cannabis, which is still federally illegal, in the house, their fair housing protections get thrown out the window. Now, I don't know the law in California, and it wouldn't surprise me if there's state fair housing protections that, do as well as the federal, but that's certainly not the case in most states. So, for example, if anyone in Oxford House was even inclined to want to allow medical cannabis in a house, which for the record, they're not, and most of us think that would be a terrible idea. But even if we were, we couldn't because we would lose our fair housing protections. And I realize that's not exactly what you're studying, but something to think about as far as what decisions are being made out there in the field with different houses and such.
So Paul, I don't want to put you on the spot, but can you elaborate on why folks would think it's such a terrible reason or that would be such a terrible thing to do?
Yeah, I mean, I think if it was Rob, I think some of the points he made I would concur with. I think that the communal collective nature of recovery housing makes it more problematic because of, adjacent people's choices and the influence that can have. I also think that generally speaking, and I realize this is a huge generalization and it's just based on 20 years of anecdote, not research, but like the kind of people and the kind of substance use disorder addictions that end up in recovery houses tend to be more severe than sort of the general substance use disorder population. And perhaps they are less able to manage or navigate the use of cannabis without falling back into addictive patterns with it. Um, yeah, I'm hugely pro legalization and hugely pro medical cannabis use. Generally speaking, at least from our perspective in our organization, we just don't think there's much of a place for it in recovery houses specifically.
Yeah, super helpful. Mina, did you want to add anything to that? Any thoughts or reflections?
Well, thank you, Paul. Yeah, and I should have included some data on the severity of the substance use disorder among the residents, because that's absolutely true that the severity is quite high among the sober living house residents. So that might indeed be a reason, like Paul said, that cannabis is not working as a substitute. They're just not able to manage.
And I'm going to email you, but if I'm eligible, I'd love to be on your CAB.
Oh, thank you so much.
You read my mind, Paul. You read my mind. That's perfect. So Gilbert Ramirez dropped some information into the chat about fair housing and disability laws. Gilbert, I wonder if you want to tell us more about that, or if you would like me to read your comment. Feel free to unmute yourself.
Yeah, hi everyone. Thank you. No, just building off of Paul's comments, right? Like we we run numerous programs with city funded, right? And we deal with this issue, of course, medical and recreational use in the state of New Mexico is legal. We don't have the prescription requirement, right? So the monitoring of a prescriber, it's pretty much once you're issued a qualified medical card, you have open ability to determine your use around how that works, right? You may have some guidance and or support, whether it's, from a practitioner, but that's not really built into our state system, right? And then when we look at our federal funding, which I think was brought up in fair housing, and how do you look at accommodations, it still remains an illegal thing federally, right? And so when we're under compliance and we're under those federal programs, there's decision points that need to be made in regards to how do you implement that with the policies for your recovery housing. It's something we struggle with now. I mean, we have numerous programs, med respite programs, et cetera, for primarily our unhoused individuals in our city. And this is a constant thing we're up against, whether we allow integration with our contractor providers for use of that in public facilities and public funded dollars, right? And that's a challenge, right? Because it's that issue exactly. Are we in compliance? Does it get allowed? What accommodations do we make? Right now, it's not, and we've taken a firm stand on that just because it's an evolving thing, as well as our practitioners don't have a prescribing mechanism behind it to really substantiate why they would use, how they would use, and where it would be controlled within our facilities. So we're teasing through all of that, which this is tremendously helpful for. So that's it.
Super helpful. So I noticed that Bonnie Thomas also dropped a comment into the chat. Bonnie, do you want to unmute yourself and share your comment, or do you want me to read it for you?
Well, yeah, I just want to say in the 90s, because like I said, I know people that's recovered. I've been working in the field for like 20 years, and I have friends that opened up recovery houses in the 90s. I'm from Chicago, and what they had to do was they could use no move my arch or something. They was not getting money from the government or anything, and they had to go, day labor jobs, just so they could make their ends meet. And they would, if they get food stamps, they had to, put their food stamps together so everybody could eat. And then they had people come to their halfway house and, do 12-step meetings. They'll come in, people from the outside come in to support them, and they'll have meetings every week, but they had to, clean up work and everything. But they didn't get no government funding. So these was people just, had an extra house. They gonna have like 6 people here, and they gonna, pay, they gonna pay their way. But if they relapse, they had to go to detox. They had to keep starting over. I don't see nothing wrong with that myself. Because some people, everybody don't want to be around. If you try to recover, you don't want to be around nobody that's smoking marijuana. You got a right, for nobody to be around you, whether it's medical or regular, So if somebody wants a house just for medical marijuana, they should just have that house for medical marijuana. They shouldn't ask the other people to come in that's trying to stay clean and sober, because it's a daily task. It's not easy to try to stay clean. It's like 1 minute, 1 second, 1 hour at a time. So, people have that right. So I just wanted to say that. So like I said, I still have friends that have recovery housing, but they don't have many like they used to, because they don't get government funding. So that's all I wanted to say. Thank you.
Yep, such an important point. Such an important point about, it's not just the person who's using medical marijuana, it's the people in the house who are also exposed to it.
Exactly, yes. Okay, thank you.
So I think that we have time for just one more question. Meena, is there something burning on your mind that you would want to hear from folks? Or is there something that folks really want to make sure that they share? If not, I'm just going to thank Meena for an amazing and very thought-provoking presentation. Again, she's been very generous in sharing her email address. So if you have thoughts or comments or something hits you later today, feel free to reach out to her and also consider her generous offer to be part of her new project and serving on the Community Advisory Board. So thank you very much, Meena. Again, just an amazing presentation. We're going to pull the slide deck back up, and I just want to keep folks in the loop about things that are coming down the road with the I-STARR project. So next month, we'll start a new series of webinars that will run through December. A registration for next month's webinar is posted. It will feature Maria Paschke presenting on the role of peer respite housing in the recovery housing community. So peer respite housing is an amazing resource for folks who may return to use while they're in recovery housing, and we'll hear all about her work on that topic. So we're still in the process of scheduling other webinars, but some of the other topics we'll be addressing include overdose vulnerability among individuals experiencing homelessness, and findings from one of our pilot study directors, Justin Bell, who examined low barrier recovery housing. So we'll definitely let you know when these webinars are on the website so you can register for them. But unless otherwise noted, the I-STARR webinars are held on the third Tuesday of the month from 11 to 2 for folks who are on the West Coast, which is from 2 to 3 for folks on the East Coast. You can also stay in touch with us through various social media platforms listed on this slide. That includes our website. And on that website, you'll see information about the I-STARR training series. So what is the I-STARR training series? Well, the I-STARR training series consists of 12 webinars with separate training topics for recovery housing operators and providers, as well as for those interested in conducting research on recovery housing. So perfect. We went to the next slide. So for folks who participate in all 12 webinars in the training series, you can receive a certificate of completion and be provided with the option of being identified on the I-STARR website who has completed this training. So at this point, because the live training series has ended, we can only track completion of the webinars if you register and view the webinars on the I-STARR Learning Management System, which is also housed on the I-STARR website. If you have any questions about the training series or how to complete it, please reach out to us, and we will help you get started. If you have gotten started but haven't gotten through all 12 of the webinars, no worries. Maybe this is something that you could do as a summer project. So the reason why we're hyping this is that a number of leaders in the field contributed to this training series, and we really hope that as many people as possible take advantage of this free training. Let's go to the next slide. So while we're talking about things that are coming up down the road, let me tell you a little bit about NCARs. I mentioned briefly that I-STARR is part of the Consortium of Addiction Recovery Science, or COARS. COARS sponsors the NCARS conference, which stands for the National Conference on Addiction Recovery Science. And this conference brings together recovery science researchers at all training levels and levels of experience to stimulate an exchange of ideas and allow for the presentation of really cutting-edge research across the spectrum of alcohol and drug disorders and their affected populations. This is a 2-day virtual conference, and it's being held September 23rd through the 24th. Registration fees for this conference are fairly reasonable as far as conferences go, and early bird and student discounts are available. However, the early bird discounts will end at the end of this week on the 24th. So if you haven't already registered, there's still a few days to do so, but you want to make sure that you do so as soon as possible. So let's go to the next slide. And I think this is where we wrap up. We do have a hard stop at the top of the hour, but I do want to thank our presenter, Meenakshi Subbaraman, who just did an amazing job and provided us with just a really thought-provoking webinar, and also everyone in attendance for their attention and their thoughts on this topic. And we hope to see everyone back here again next month, and that is August 18th. But until then, enjoy the rest of your day.